since I don't know everybody, and I know we did pull in some people from other departments, I'm Dr. Graham from the Behavioral Neuroscience program here at Western in the Department of Psychology. And what we do every quarter is bring in a guest speaker that can speak to things of neuroscience or neuroscience adjacent to a broad audience. So we have our visitors here in person. We do have some people that are on Zoom. And so for this entire audience, I'm really excited to introduce our speaker, Dr. Gaetz. I have your little background from the internet here, from the School of Kinesiology in the University of Fraser Valley, and that's from the location is specifically in Chilliwack, British Columbia. And your education is very BC-ish. Your bachelor's from in psychology, Simon Fraser University, Master's of Science, Kinesiology, Simon Fraser University, PhD Kinesiology, Simon Fraser. As well, you did postdocs at UBC, University of British Columbia, both in sports medicine and psychiatry. You have American Board Registered and Evoked Potential Technologist and Certificate in Interoperative Neuropsychologic Monitoring. You've been actively engaged in research on concussion in sport for at least 20 years, and you've published a whole bunch of really interesting things. If you get the chance to do a PubMed search, there's some interesting things that will be brought up today, but probably not everything. So we're talking about experiences of athletes, including hockey players, but not all. There's a lot of hockey, right? Other research interests are in quality of life in the elderly, in the effects of weight cutting in combat sport. Your clinical background is as a neurophysiologist working in the operating room, using electrophysiologic procedures to monitor brain and spinal cord functioning during high-risk surgeries. You're speaking on sport concussion and chronic traumatic encephalopathy today. Please welcome Dr. Gaetz.
Well, thank you. Thank you, Dr. Grimm. Thank you to everyone, actually, giving me a really warm welcome today. I had a great tour today. Looked at the wonderful labs you have here and infrastructure that you have here is very impressive. Cadaver labs and things that are hard to come by in a lot of other universities that are even larger than this one. So you're going to a really good school, I would say. So we had lunch today, and there were some students at the lunch with me, and I asked them what would be a good topic to focus on, because when I do this talk with our undergrads, we have classes that are typically an hour and 20, and we have an hour. So the consensus was we would focus on the pathophysiology and then transition a little bit into CTE and CTE science to give you a sense of that. And if we can accomplish that, that's great. There's other research that I've done more recently that we can talk about afterwards in a Q&A format. But it's 1 hour, correct? Yeah. Okay. So this is what I hope to accomplish today, at least the first 4 bullet points. What is a concussion? What's the difference between a concussion and CTE? CTE is what you hear about most oftentimes in the media and what have you. Talk a little bit about CTE science, how CTE scientists go about their business and making their claims, and then a little bit on a model or theory that I developed in 2017 that has been used in the field to guide thinking on some of the antecedents to CTE symptomology. And if we get to the bottom one, great. Okay, so one thing that we'll be doing is checking in on where you're all at with your concussion knowledge. So we'll talk a little bit about facts and myths related to concussion, focus a lot on the early part of the talk on the pathophysiology of concussion. When I do this talk, I'm the director of a school of kinesiology, so we have a lot of athletic therapists and kinesiologists, so I do include a little bit on concussion signs and symptoms and the difference between those, and I do that because they need it, but I also do it because we want to look at that in CTE. What's the constellation of symptoms that you'd expect to see with CTE symptomology? And then lastly, prognosis, because that's relevant and important. Okay, to you. Some questions, true or false questions. First one, concussion is caused by a bruised brain. True or false? What do you think? I see one thumb down. I have one response. More, okay. All right. Not caused by a bruised brain. All right. We'll see the answers in a moment. Concussion is caused by whiplash, a whiplash injury to the neck, causing a lack of blood flow to the brain. Mostly thumbs down, a couple thumbs up. Okay, you did pretty well there. Concussion is caused by a bruised brain. Not true, not correct. If that was the case, then it would be really easy to image with standard imaging, and it's not. That's part of the problem, is that we don't see a concussion injury show up easily on a CT or an MRI. Concussion is, oops. I'm just going to keep going. Concussion is caused by a whiplash injury to the neck. See, that's why that's false. Movement of the head will cause concussion. We know this, but it's not due to a lack of blood flow in cerebral artery, or the arteries that run through the neck, let's say. So good job on that. Okay, let's see how you do on this one. Concussion results in a temporary disturbance of brain function with no permanent effects. I saw some thumbs up, mostly thumbs down. I'm really liking the thumbs down and thumbs up thing. We don't do that in Canada too much, but it's working here. Okay, false. Most of you had it right, false. The interesting part about this specific question is when I started studying this, that was the definition of a concussion. Temporary disturbance, no long-term effects in the brain. So we've come a long way now. In fact, we were talking about pendulums and pendulum swinging at lunch. We went from that definition to, oh my gosh, this is an epidemic and every athlete that ever hits their head is going to be damaged. Now we're back to sort of the middle ground. Okay, so in terms of the pathophysiology, what is the pathophysiologic agent? It's acceleration, deceleration forces applied to the brain. So it's not about blood flow. This is about movement of the brain within the cranial vault. So the brain moves, what happens to cells? And not all cells, some cells. They stretch. You get a stretching effect. Where? Well, the longest part of a pyramidal cell, the axon. What makes this challenging to image and work with clinically is this damage is happening in a very diffuse manner. So you don't see it easily or at all really on standard imaging. In terms of neuronal outcome, when you stretch a brain, you can have a range of the cell can die, or it can be sort of in this metabolic zombie state, or you can see some level of recovery. But there is cell death with every concussion. Now, I'm going to get out of this temporarily. We're going to try and go to a video. So I'm going to go to Zoom. I'm going to try to go to Zoom. Nope. See, I think that was the sharing screen right there, but I can't find it now. Okay. So we want to stop sharing this here. Just like, I can just click on the thing. Okay. And now we can go to this and share. Can you see it? Yeah. Okay. So we didn't stop it. That's what's happening. No. No, I may have to skip it. It's too bad.
Just go outside. Yeah, just go outside and breathe into those.
To like shift it from out of.
Neil.
Shagas. What? Where's your PowerPoint? Where's your video?
It was loaded on YouTube. So maybe here.
No, but it should be in, if it was loaded in YouTube, then you've got to go to YouTube to watch it.
Yeah,
right?
that's what we're trying to do.
Okay.
I had it loaded up on YouTube. It's okay. We don't need to show it.
You can. Do you want to just go to youtube.com? Like
Yeah.
do it like that way?
That's what I did
Oh,
before.
like in this way?
Mhm.
Okay.
Okay.
And then just find it that way, and then you can just share that screen instead.
Okay.
If it was a Mac, it would just work.
Yeah. This.
That one?
No, the full one. We could try this one. Okay, so we got to share that now.
Yeah.
And then share. That one.
That one, yeah.
Okay.
And then go to share right there. Perfect.
So here's another true and false question. True or false, is that person conscious or unconscious? Actually, maybe you just have to answer. Are they conscious or unconscious? Yes or no?
They are one or the other.
They're, you got a 50-50. That person's unconscious. And it's one of the things that's kind of, if you're working with people on sideline or what have you, and you're trying to assess athletes in real time, and you see them moving, and they're moving typically their upper limbs. What's happening in the brain is there's a lot of excitation happening. A seizures occurring, and you're getting activation of motor cortex, and you're getting movement of the upper limbs. But that person is not conscious at the moment, which is a little bit unnerving. And I've seen it live twice, and it's not a pleasant thing to see. But the main thing that I wanted to show you with that clip, because it's really clearly shown, is how quickly the head has moved rapidly and then stops, hits the turf, and inside the cranial vault, you're getting stretching of those axons. Okay, so now we're going to stop sharing this screen. I go back to share, and I go back to this one. Okay, works? Good. Okay, so we have axons. Now we're in stadium mode. Okay, good. We have axons that make up part of the brain. We also have smaller cells like glial cells and what have you. But it's the axons that we're interested in here because they have the long projections, which is the axon. So we're looking here as the part of the brain and the cells within the brain that are susceptible to those stretching forces, the acceleration, deceleration forces. So on a lot of the lab work that you're doing, you're able to see some of this white matter in the mammalian brain, but the human brain is amazing really because you have all of these billions of cells connected together with these substantial white matter tracts. So imagine gray matter connecting to all of that white matter, and the gray matter is heavy, and when you get movement of the brain within the cranial vault, it acts like a ball on a tether, and the tether, these are the white matter tracts. So when you're pulling on the white matter, you're stretching the axons. You can see a white matter tract here, and you can see small little nodes of Rambier there. So when you have that stretching effect, that's when the pathophysiologic change starts to occur. And for a long time, scientists thought that when you stretch cells like this, they'd actually tear. And right up until the time that we started to study this, that was sort of the lore, was that you're going to have some stretching and then eventually tearing, and it was called a shearing effect. And shearing is a term from physics, but I'm going to explain something a little bit different. When we have stretching of axons, we actually get a disruption in the ionic flow across the axonal membrane. The first thing that happens is you have sodium ions entering the cell. And how does that happen? Well, when you're stretching the axolemma, you're getting those ion channels to open up. So sodium's entering. And that's the beginning of the pathophysiologic process. So what happens next? You get a reversal in the sodium-calcium exchanger. Net result there, calcium ion in the cell. And that starts excitation, and you have more calcium entering. So what you're entering into here is something called calcium excitotoxicity. And that is why you see that seizure occurring, because you have neurons that are now activated and firing. So this is the beginning of the pathophysiologic process that would cause that athlete to behave in that way or just lose consciousness. Those of you who study epilepsy know that when you're having a seizure, you're not going to be remembering anything. And that's because you have disorganized firing in the brain and a lot of it. So you don't have the precision to create memories and a flow of consciousness. So back to the shearing bit again. And that, in the 50s, there was a researcher by the name of Sabina Strick. And she talked about, with brain injury, actual disruption or tearing of those axons. But you can see here that you can actually stretch axons up to 65% of their resting length without having them tear at all. They stretch and they kind of look like an elastic band. And then over time, they go back to their resting length, and they don't look as straight as they did before, but they're not torn. So there's a lot of elasticity and resilience up to 65% of the resting length that would occur prior to any kind of tearing. So how much stretch can we see happen before a secondary pathophysiology starts to occur? The science that I've seen so far, animal modeling, suggests that if you have mild stretching up to 5% of the resting length, you're not going to see any changes in structure, and the cell will regain its normal functioning again within minutes or hours. But if you get into this range, greater than 5%, 5 to 10%, something different starts to happen. So imagine an axon that's been stretched. Now, the primary parts we focus on are like myelin sheaths and ion channels and things like that. But we also know that within the axon itself, there's a cytoskeleton, there's tubules that are allowing for axoplasmic or axonal transport of products from the cell body to the axon terminal and back in the other direction. And when you get stretched beyond that point, you disrupt that cytoskeleton. So what happens to the cell is, as products are flowing bidirectionally in the axon, they can't make it past this point because of the disruption in the cytoskeleton. So what happens? You start to see swelling on either side of that disruption, and it swells and swells over hours and days, and eventually swells so much that it separates. And that's why people thought axons were torn, because they'd look 30 days, what have you, after severe brain injury, and they'd see these cells that look like they were torn, when in fact they're not. And this has been demonstrated clearly with animal modeling. In the minutes and hours and days that follow something that represents axonal stretching in an animal model, you see this pathophysiologic process occurring. And so what's the long-term outcome for these cells? Most of these cells would die. And so that's what the cells are looking like after you've stretched them, and you get this swelling effect. And some reach a state of equilibrium where the swellings persist over time, and those cells are sort of in that zombie state. Others blow up and basically you've separated the axon, the cell body from the axon terminal. So in terms of force applied to the brain, is there one that's worse than another? The one that you just saw with the football player, that was more linear in nature. The person's head essentially snapped back and they hit the turf with the back of their head. That's bad, and it's obviously, you know, how much force are you applying? But typically rotational forces, you know, getting the head to move like this, those are worse. Because of the morphology of the brain, you're getting more disruption of the axons, especially when they cross over at corpus callosum and other structures. So rotational forces are typically worse than linear forces. And those of you who do follow combat sports like boxing, mixed martial arts, you will be able to see and pay attention the next time that you watch these things, that if someone's hit like this, it gets their brain moving a lot around the axis, which is where their neck meets the base of their skull, and it accelerates it quite quickly, and you get a lot more damaging forces that way. Okay. So what about the vascular system? Does that play a role? It's not necessarily playing a role in terms of the pathophysiology, the pure pathophysiology, which is this stretching of the axons and the disruption. But is there a change in blood flow to the brain, let's say, in the resting state? And there's some science to suggest that that's the case, and some science that suggests it's not, and it might be depending on what experimental paradigm that you use. But typically we don't see changes in the neurovasculature in terms of leaky vessels and things like that. In fact, if you do see a bleed in the brain, you've already elevated yourself past concussion and you're into mild to moderate TBI, because that's going to elevate your Glasgow Coma Scale score. But again, that's what makes this a tricky or difficult injury to detect, because there is no change to the neurovasculature. What can we expect to see in terms of blood flow to the brain? This is what I was alluding to a few moments ago. Some studies show that you're going to see a reduction in resting blood flow to the brain following concussion, and you can imagine how that would affect cognition. There's some research to suggest that in certain, probably more rare situations, you actually see a significant increase in blood flow in the brain, cerebral hyperperfusion. And that has been discussed not so much anymore, but it was really pretty topical in the early days of concussion research, related to something called second impact syndrome. Have any of you students ever heard of second impact syndrome before? 2 hands, 3 hands. This would have been almost thought of as synonymous with concussion back in the earlier days of research, and it's completely different. Second impact syndrome is when cerebral autoregulation essentially fails, and we get into this positive feedback state where you've got significant pressure building in the brain. And the problem with it is that if you have that state occurring, you've had a concussion or an injury that's causing this hyperperfusion, and then you have another concussion, that will actually cause death. It's very rare, but people have died from second impact syndrome, and it's this positive feedback cycle that starts to occur with the second concussion when there was substantial brain swelling. So that's in the resting scenario. Some hypoperfusion studies, some hyper, they're more rare. When we look at activation, so some cognitive activation associated with various tasks, memory tasks, and what have you, we see the brain working harder. So here we have one of the earlier BOLD studies, an fMRI study that clearly identifies the brain lighting up more blood flowing to those areas. The brain is having to work harder following concussion. And that study was done by a very famous scientist, preeminent concussion scientist. Last name I think is Jansen. First initials KJ. So KJ Jansen was I think the first person to do this type of neuroimaging in concussion when he was at Florida Atlantic. So yeah, one of the early concussion scientists working here with you. Okay, what about cumulative effects? We hear a lot about cumulative effects, maybe less so now. But there seems to be this change that occurs with each successive concussion where we expect to see the subsequent concussions being more severe. They happen more easily. Self-reported symptoms go up. And while there's no magic number to the number 3 experimentally, that seems to be a meaningful place to look for changes that are more substantial with each concussion. So these are some of the things that you can see in individuals who have more than 3 concussions experimentally. So some of the early work we did when we're still at Simon Fraser University in Burnaby, we were working with hockey players who had a significant number of concussions versus those that didn't have concussions. And we were using event-related potentials. So here we have an N2P3 paradigm for words. And what you can see there is in the group that has had a significant number of concussions, as a group 3 or more, they've got about a 40 millisecond delay in their brain responses compared to the group that had no concussions. So those of you who've done some work like this know that in the brain, 40 milliseconds is a long time. And these are very young people. These hockey players are, the oldest would be in their 20 years old, and some of them are 16, so 16 to 20. So you're seeing substantial changes in how the brain is functioning in very young people. You also see increases in symptoms in those people. So here we see in darker blue, the 3+ concussion group, and significant changes in symptom reporting for memory, concentration, the ability to think. So if you look at those symptoms and you compare them to latency, the ones who had the highest symptom reporting were the ones who had the longest latency. So we see it's not always easy to correlate neurophysiologic responses with symptoms, but here it actually worked. And what's important here is that these athletes they weren't recently concussed. These were baseline data that we were collecting because we did baseline testing and then waited for them to have concussions after that. All of those athletes had not had a concussion for a minimum of 1 year prior to assessment. So those changes in latency, that was after a minimum of 1 year recovery. So those weren't acute changes. They were already after some substantial recovery time. Okay, more questions for you. You must sustain loss of consciousness to be diagnosed with a concussion, true or false? That's pretty unanimous. Well done. How about this one? Concussions with loss of consciousness are the most severe form. Ooh, that's 50-50. Actually, I think we got more thumbs up on that one. Okay, so there's still some benefit in doing this. That's good. When I started to do this, years ago, most people wouldn't get these right. So you're doing a lot better now, and that's good news. So you had the top one right. The bottom one, it's actually it's not good to have a loss of consciousness, but it's not an indicator of the most severe form. Typically, and this is why accurate sideline assessment is really important, and knowing your athletes is really important. It's disruption in memory that is a better indicator of the severity of concussion than loss of consciousness. So while not good to lose consciousness, it's not the best indicator of severity. So again, when I speak to our students, most of them are going to be kinesiologists or athletic therapists, and that's why it's really important for them to know that, because being accurate with your assessment on the sideline and knowing when somebody's really having difficulties with memory following an injury becomes really important. Okay, so here's a set of practice guidelines and expectations really that are pretty up to date. So you get a good sense of what you can expect on average if somebody has had an injury. So there's people that KJ and I know in here, someone that we've worked with or I've worked with pretty closely, Grant Iverson, Noah Silverberg's at UBC. So these are signs. We'll start with cognitive signs, then physical signs, then we'll talk about symptoms. And symptoms are important because we're going to transition into CTE symptomology and look at the overlap there. So if you suspected a concussion in an athlete, what are some of the things that you look for on the field? So, you know, that football player was pretty obvious, but sometimes it's not obvious. Sometimes there's a tackle and someone gets up, and what kinds of things are you going to be looking for? Things like disorientation. Do they know, are they going to the right sideline? Are they in the subsequent play? Are they running in the wrong direction? That's been done before. Do they look confused? Was there any evidence of loss of consciousness? So physical signs, those are maybe more the things you can look for on the field. Do they look wobbly when they get up? Did you see a concussive convulsion like you saw in the football player? When you're asking them about things on the sideline, how are they responding to you? Are they accurate, first of all? Are they responding slowly? Are they distracted, or can they pay attention? Do they display inappropriate emotion? Now that's an interesting one. And again, where knowing your athletes is important. It's an odd thing to see a huge football lineman sitting on a sideline crying after they come off the field. But it definitely happens, and not following a championship loss or anything like that, just after a really hard hit on the field, or laughing inappropriately. Again, it's why knowing your athletes and what their personalities are like is really important. But essentially, emotional dysregulation, as you know, would be indicative of perhaps frontal dysregulation. Some of the other things, throwing up or feeling sick, you could ask them about that. But if they're actually throwing up, that's something that would be an indicator of a physical sign. If you're looking at their eyes, it's actually something that's really difficult to describe with words. You'd have to see it, but it's a very characteristic look. The eyes have this very glassy appearance that is indicative of something happening in that region neurally. Slurred speech, personality changes, inappropriate playing behavior, and sometimes a decrease in playing ability. But there are cases, and this is where it's hard to have these conversations sometimes with coaches, that players actually play better after they've had a concussion. And maybe it's because they're less inhibited, a little more dysregulated, and willing to do things that they wouldn't normally do. Okay, now on to symptoms. So you'd have to be asking the concussed individual about these symptoms. So do you have any pressure behind your eyes in particular? Concussion headache is pretty oftentimes very specific. It's like a headache, but it's a headache that occurs behind the eyes, if it's significant or purely related to the concussion. Now, you can have a history of migraine and it could be different, but typically if it's just related to the concussion, it's behind the eyes. Asking them about problems with dizziness or balance, feeling sick, feeling foggy or dazed, vision and hearing problems, pretty rare, like double vision or problems with hearing. Irritability and emotional changes, that one can actually occur. Now, for clinicians, this is really important. You have to be very aware of the injury history for an individual, because any one of those things on that list have a symptom profile that overlaps the concussion symptom profile. So if they have a concussion and they have a history of mental health challenges like depression, how do you disentangle the concussion from the mental health problem? It's, again, why diagnosis of a concussion is very difficult. And any of these are in that category. Whiplash injuries, very common with concussion. Car accidents, for example, you hit the car in front of you, your head snaps forward, you've got a cervical strain and you've got a brain injury. The cervical strain in and of itself can cause some of the same symptoms that concussion can. Not for the same pathophysiologic reasons, but the symptoms overlap. So knowing whether any of those things is occurring is very important when you're trying to diagnose and manage concussion. So these are some of the high points or main points pulled out from that paper that I just showed you. And it's sort of an amalgamation or a summary of where we're at with the science for expectations with recovery. So as you can see there with the first bullet point, most people recover from a concussion fairly quickly. It's actually pretty rare. 1 in 5 people will have symptoms that persist for longer than 1 month. Children are a little bit different for a lot of different reasons. One is that their brains are still plastic, and the other is that they may not be experiencing the same level of trauma that we'd find with adults, but they typically go back to their activities with a median of 2 to 4 days. For adults, getting back to work or school, it's most typically 1 to 2 weeks. Rare cases, 1 in 5, 6 months. Now, it's not parsed out in terms of which cases were medical legal and which ones were just normal recovery, but you'd have to think that if it's very prolonged, there could be another factor there, which has to do with whether or not there's a lawsuit that's pending related to the injury. The good news is, and this is different than how the story started out, especially after 5 to 10 years of research, is that there's really little evidence for lasting objective impairment in cognition or academic performance after a concussion. So if we give the brain enough time to recover, and that's key, especially when we're dealing with athletes, we don't get them back to play too quickly and then have another concussion within a short period of time, the outcome is typically good. Top bullet point here. Girls and women may take longer to recover than boys and men. Although the science here is a little bit mixed, but it makes some sense, especially with younger athletes. When you have a difference in the development of the musculature in the head neck segment, and you apply the same forces to the body, it makes some sense that the head would move more in the individual that doesn't have as much strength here. And so we have a bit of a lag with girls compared to boys in terms of the strength of the neck. So until they catch up, they may be more susceptible to having more movement of the head and the brain. Some other things that we can talk about before we transition on to CTE. History of prior MTBIs and the intracranial abnormalities like day of injury CT are inconsistent predictors. There's some predictive value there, but they're typically not great predictors of clinical outcome. Symptom volume, the symptom burden that's experienced right after the injury is typically the best predictor. And very importantly here, in adults, knowing about challenges with mental health, knowing about psychological distress, depression, anxieties, things like that, they're very important to know about because they're going to significantly impact recovery and typically create a prolonged recovery. Okay, so 15 minutes left. How does concussion relate to chronic traumatic encephalopathy, which is what we hear most about in the media today? So we have these very famous cases of well-known athletes that we hear about in these press releases. So here's a hockey player example. Derek Bugard was an enforcer. Does anyone know what an ice hockey enforcer is? Who can give me a quick definition? They fight. And in their heyday, which would have been 70s, 80s, maybe a little bit into the 90s, they would almost exclusively fight. They'd play a little bit of hockey, but they were there for another reason. So that individual, his main job was, yes, playing hockey, but primarily fighting other enforcers. Here we have an NFL example, Junior Seau. He died via suicide and had CTE in his brain. So we get these press releases that come out periodically, and as I'll show you, primarily from one university in the East Coast. So this has led to obvious changes in how sports regulated and lawsuits, like the NFL lawsuit with the Players Association. The man that you see in the center frame there is Bennett Omalu. He was the pathophysiologist who identified the first case of CTE, and I'll say modern day CTE, and is really one of the people who created this scenario where they'd find a case and then they'd put it out into the media. And it led to a lot of concern from parents with kids in contact sports or sports even like soccer, that they didn't want their kids exposed to events that could create a terrifying link between concussions and suicide. This has even, as you know, led to a movie. So something that came up at lunch was how many scenarios do you know of where the science is ongoing and they make a movie about it? It's pretty unusual. So what's happening here? Where we have these high-profile cases, and part of that is they're high-profile and they're athletes. But we have this sort of narrative that's been formed in the media, and it's really colored how we view sport and neurotrauma within sport, especially for certain sports like football and hockey. CTE has been around a long time, discussion of CTE. Another thing we talked about at lunch today was in boxers, there's a really large literature from dating back to like the 1920s. In boxers back then, there was, they would call them club fighters. They would fight every week. I know. So imagine what that would do to your brain. So there was actually a lot of study that was done on boxers who would, be participating in these club fights on a weekly basis. And there'd be substantial changes in their brain. It frankly looked a lot different than it does with the modern day CTE, but it was fairly well documented. Modern day CTE shares some of the characteristics that we saw in those early studies, but not all of them. In particular, the symptom profile for modern day CTE is very different than it was with these athletes that had substantial damage to their brain. So CTE scientists describe the process as such. Repetitive neurotrauma triggers progressive degeneration of neural tissue and the buildup of tau protein in the brain. The buildup of these proteins can occur during the career, transitioning out of career, or even into retirement, which always made me wonder what's going on. If the tau buildup persists into retirement, what's actually happening here? So this is what it looks like in the brain. You can see over here on the left, a brain from an individual that wasn't involved in sport, didn't have a history of repetitive neurotrauma. And then you see over here in the center and right, you can see the buildup of the tau protein and what that looks like under the microscope. So along with the change in brain that you can only obviously detect after their individuals passed on, like diagnosing Alzheimer's disease, for example. In addition to that, you get this unique symptom profile, and it's quite extreme and unusual. And a lot of the time it looks like something like this. So here you have an athlete that's saying, yeah, while I was playing, I was fine. But as I was starting to transition into retirement, things really started to change. I started to have a lot of extreme emotions. I started to think that I was going crazy. And then because of the cases that have been published, they start to think, I have CTE. I think I have CTE. And one of the hallmarks is this real substantial emotional dysregulation, sometimes described as explosivity of emotion. Here's a second one, and there's suicide that's linked to a lot of these cases. So here we have another individual in retirement, had bouts of depression, attempted suicide, there was paranoia, and eventually committed suicide 11 years after retirement. Okay, so here's a list of CTE symptomology. These are the symptoms that you would never have found in one of those early cases with boxers. Suicidality, impulsivity, explosivity, aggression. The others, yes. And in fact, there was a substantial reporting of motor symptoms in those early cases that you don't see in modern day CTE, unless the case is very extreme. So what's going on here where we have in historical, if you want to call it that, CTE, this constellation of symptoms that looks quite different from how it looks today? Let's talk a little bit about the science behind CTE, because it seems like a pretty substantial problem. So here we have some quotes from CTE scientists. CTE has been described as a neuropathologically distinct progressive tauopathy with a clear environmental etiology. So what is the clear environmental etiology here? Neurotrauma. Repetitive neurotrauma. Yeah. It's the only known neurodegenerative dementia with a specific identifiable cause, in this case, head trauma. And so those are from 2009, 2011. So I looked more recently and I was wondering whether these definitive causal statements are still being made. Here's a quote from 2025. Repetitive head impact exposure is the only known risk factor for chronic traumatic encephalopathy. So those of you who've already done your research methods classes, you can characterize these statements as what? These are causal statements. If A happens, then we expect B to occur. Correct? What is the research burden of proof to make statements like that? Yes. Like we talk about prospective studies or something with an experimental intervention. So at a minimum, we should be doing some prospective studies. So to date, how many prospective studies do you think that there's been done on CTE? With, on the topic of CTE. How many think more than 20? Okay, see a few hands up. It's not more than 20. How many think more than 10? Notice I'm going down, not up. How many think more than 5? How many think none? You do, because you know. None. Yet, you see definitive statements being made. CTE is case-based science, largely. So what does that look like? And this is something I pulled from this year. This was published this year. We still don't know the rates of prevalence for CTE. So for every individual who's been exposed to repetitive neurotrauma, we don't know how many of them are going to develop CTE. We don't know the pathophysiologic origins of CTE. We know that people have died with CTE in their brains and they've never been involved in sport at all. And they don't have a history of abuse. They don't have any neurotrauma history at all. So what's going on? I think that would be considered unusual in science. So how are CTE cases identified? We're getting close to the end here. Typically, CTE cases are donated by families of athletes who have had difficult endings to their lives. And they want answers. So they're self-selecting to have the brain studied. If we want to do this prospectively, I've got a bit of an image in the next slide that would show you what that would look like. But as of right now, either the families are donating the brains or the CTE scientists are making phone calls once they hear about a suicide in the media and getting the brains that way. They're not being studied in a systematic or prospective way. Obviously, this will lead to selection bias and case selection bias. So at present, if this was an entire league of retired athletes, every one of those spheres, some of them may have CTE symptomology. But at present, CTE scientists only pick those that have the symptomology instead of looking at all athletes that had similar exposure to repetitive neurotrauma. That is what needs to be done. So I think we have enough cases to indicate that, yes, if somebody has a difficult ending to their life into retirement and we look at their brains, there's a high likelihood, not 100%, but a high likelihood we'll find CTE in their brains. But if we really want to get a handle on this, we need to understand what the likelihood is for anyone who's had repetitive neurotrauma. So to the point of what's going on, there's one university in North America, in the world really, that has been responsible for the majority of the science in CTE, and that is Boston University. They're also responsible for over 50% of all press releases associated with CTE. So one university and one group of scientists is driving the international narrative on CTE in a substantial way. So I'm going to have to speed through this part. What else do we know about athletes? You think about football, you think about hockey, you have a long history of high impact. You're going to have chronic pain into retirement due to musculoskeletal injury. What else do we know? Especially as you get into the 2010s and beyond, substances for management of pain and even things like management of sleep, because athletes are asked to travel through different time zones and perform at a high level. They're using these substances more and more, or they certainly were at a given point in time. We also know that athletes, many athletes, not all athletes, have to dedicate so much time and put so much emphasis into becoming an athlete as they, move from childhood to adolescence to adulthood, that they don't have time to develop in any other way. They don't have time to develop normal social relationships. They don't have time to develop any other skills. They've locked into this exclusive identity. So when their career is over, many of them don't know what to do anymore. They don't even know who they are anymore, because the only person that they understand is in the context of sport. So this led me to develop in 2017 a model to help explain this. Okay, we're literally out of time. I'm going to jump to the graphic for a second here. The model is like this. If you're looking at an athlete who's in his retirement years or her retirement years, and they're having a difficult time, there's a significant or substantial literature that can help us understand that. One factor would be neurotrauma. So you wouldn't even suspect somebody has CTE if they don't have any history of neurotrauma. But there are other really important factors to consider as well. A history of chronic pain, substance use, and athletic career transition stress is the scientific label that's used to describe transitioning when you have high athletic identity. So I'm going to back up here for a second. And if you look up here, these are the constellations of symptoms that CT scientists describe. You have a whole host that are cognitive, behavioral, mood, and then over here, motor. If you look at the research literature, the peer-reviewed science on athletic identity and transitioning out of sport, athletes with high athletic identity have substantial changes in mood into retirement. So that's just athletic identity and career transition stress alone, with a little bit of behavioral, and that's where you find the explosivity, impulse control, and so on. Chronic pain, there's a substantial literature on chronic pain and changes in cognition, behavioral changes, mood changes. Same for substance use. And so you've got all of these articles that have been published over the years that tell us that if you have any one of those other factors, you have a pretty profound likelihood that you're going to have high levels of CTE symptomology. And we know that these things are occurring in athletes. So this is where I was in 2017. And since then, I've actually been looking at a group of athletes, which are these ex-professional ice hockey enforcers, to see whether they do have high levels of CTE symptoms. And if they do, is it purely related to neurotrauma, or do they have some of these other problems occurring as well? So that's some of the things that I can talk to you about afterwards, because we're up against the end of the time here. But in summary, what I will tell you is that in a sample of ex-professional ice hockey enforcers that had on average 200 fights in their careers, none of them have high levels of CTE symptomology. You think they would, because they had careers where they were exposed to substantial repetitive neurotrauma, but they don't. And they're actually not happy with the narrative, most of them. Okay, so that is my hour, at least an hour and 3 minutes. So thank you very much for your attention. I appreciate it. And I don't know if we have time for questions, or we can do that informally.
Kind of into your lapel, because Janine's out there. We're gonna take some questions here. So the Zoom is, as long as Janine's available to keep running it, we won't mess with it on this end. But we'll do questions for 5 or 10 minutes. If anybody has to go, of course, go. I'll take a cookie with you, but otherwise stay. We have the room until 5:30. Let's do a first little thank you, though.
Okay, yeah, if you have to go, totally understand. We're over time as it is. Okay, questions? I don't know, but it would make sense, right? You would think there's obviously a lot of animal modeling that's happening presently. Most of it's murine models or rat models. They still have not come up with a good way to explain how the tau proteins aggregate. Something really different is happening with CTE brains, in that a lot of the tau aggregation is perivascular. So that, again, why is that? There's attempts at animal modeling, but none of them have come up with a good description of, they can't essentially recreate the patterning and the tau development. Yeah. Sorry, in the back, and then.
Could you repeat your question?
Yes. are there any theories to help us understand the difference in symptom profile for historic versus modern day CTE? No, because no one cares about that. I'm probably the only person I've ever seen that just talked about it or written about it, because I grew up in a family that liked boxing, and so I had an interest, and so I value the literature that exists, even if it's older, and no one's ever, certainly not to me, provided me with an explanation. I mean, my explanation is that the explosivity, the emotional dysregulation, things like that, I think are better explained with some of these other elements. I mean, if you just look at the substance use literature alone, we have a whole host of different substances that had started to make their way into pro sport when salaries really started to increase around 2010 in hockey and football, a lot of different sports. There was a lot of motivation to extend your career or stay in the lineup so you didn't lose your job. And so you saw more steroid use. In hockey, there was none up until then. And then you start to see more and more steroid use. And we know that if you're taking steroids during adolescence into early adulthood, that dysregulates parts of your brain like your HPA axis, for example. And then you add opioids, and then you add sleep aids. Those kinds of things alone, I think, help explain a lot of it. And then athletic identity, whole other level there as well. But no, I don't know of anyone who's looked at it.
By that, like stretching, that people start to have issues with like coordination between their running brain.
I don't know. To me, that sounds like something that would be more along the lines of moderate to severe brain injury, and then you're getting into all sorts of motor dysfunction and dysregulation. These are still relatively subtle injuries, and again, that's why they're challenging to detect and identify. But yeah, I don't know. I think here then there. Yeah.
Now,
I don't think the literature in CTE is that substantial. We know that there's like the APO E4 allele in Alzheimer's that seems to account for some of the progression in that disease state. I think if there is any, it's very preliminary. So I don't think that there's really I don't think there's really a smoking gun. Even with Alzheimer's, there's not really. It accounts for a small number, small percentage of cases, but I don't think that anyone's identified anything like that yet. Oh, epigenetic, I haven't seen a study on epigenetics in CTE. Makes sense that there would be, but sorry, yeah.
Symptoms in concussion at like the 3 threshold, like the more permanent one versus like a sideline symptom.
Differences in severity.
Like so, like the more longer term in the after you get 3, is it like more of just a moderate permanent cognitive latency versus like on the sideline when you have an immediate onset?
Can you repeat his question?
Sorry, I'm still not quite clear on the question. And then maybe one more time, and then I'll try and repeat it.
Like the cognitive latency.
Yeah.
Caused by the concussion. So, and once you hit 3, it's more like it remains.
Well, I mean, we didn't study beyond a year, but at least at 1 year in young people, that was a pretty substantial difference. So what would that link to symptom-wise? I would say problems with cognition, problems with memory, anything that has to do with cognitive load. the speed at which you process information, makes sense that that would be impacted. And that's what we saw in the symptom profile as well. So that was a question about the latency that we saw electrophysiologically and the symptom burden that you'd expect to see in people with 3+ concussions.
The narrative questions right now. But I know they recently conducted a study that basically indicated that some excessive impacts and just overall the accumulation of impact over time also causes axonal strain, and then can lead to some behavioral and more mental health problems later in life. So I was wondering if you knew about how. So
Oh, absolutely. It's not any impact that they're talking about is on a continuum, obviously, but it's not severe enough that you'd see, like Tua. It's the head slap that linemen get 50 times a game. That level of impact would be included in their repetitive neurotrauma model. So it doesn't have to be something so severe you'd say, oh, that person has a concussion, but or heading a soccer ball, same kind of thing. I think it's always been there, to be honest. I think you're talking about a cumulative career-long series of, almost undetectably mild to pretty severe neurotrauma events. And it's all just physics, right? Like how much force are you applying to the head and, how much acceleration and deceleration is occurring. They're not discounting any of those. Even if they're on the very, very mildest end, they're including it all in a history of repetitive neurotrauma. I think that narrative has been there almost from the beginning. What about you over there? Yeah, you're good. Your hand was up. Yeah. See?
Retired female athlete and retired male athlete, or is that not super carefully researched?
Well, that's a great question, and it parallels. Yeah, essentially, is there a difference in the symptom profile in CT cases for women and men? Is that, yeah? Well, first of all, like most sports science, there's significant underrepresentation of women in the scientific record. So if you're looking at the proportionality, there's, a handful really of studies in CT on the brains of women. I don't even think there's enough of a sample there that you could even answer the question, to be honest. And some of that is women aren't participating in collision sports to the degree that men are. We see women in hockey, for example, but there's no body contact, there's no hitting in women's hockey, whereas there is in men, so they're automatically being exposed to less impact. So I don't think that we can answer that question yet because there just isn't enough of a sample of CTE in the brains of women yet. Uh-oh. You might not want to ask that question. Yeah, go ahead.
Have any informed guesses based off of your expertise to what is causing that CTE in patients without a history of?
Well, there is a parallel literature on substance use, especially with opioids, where you do get the development of tau proteins. So there's that. Sorry, I keep forgetting. Yes, if it's not related to repetitive neurotrauma, what is causing it? What are some of the other possibilities? Some of the other possibilities: history of substance use, in particular opioids. That's one. here's a scenario that I think is possible. I think it's possible to have the development of these tau proteins and be asymptomatic. I think that if you did the prospective studies, you'd probably find a lot of, well, there's a very recent study, 2024, that was trying to link a history of being an enforcer with a history of the development of CTE. Statistically, no effect. However, in 24 of the 25 brains of hockey players that they studied, there was evidence of CTE in 24 of 25. So that tells me that repetitive neurotrauma is likely causing some of the tau buildup, but I'm not sure that you're going to see substantial symptom profiles develop in all of those individuals. So is there a true link between the tau buildup and the symptomology? We don't know that. And I don't think it is actually the case because a lot of those individuals didn't report a high symptom burden. Yeah, I mean, I played hockey for 45 years. So just based on that alone, I should have CTE. So you can invite me back in 10 years and see if I can finish a conversation. I mean, I guess we could do that. But going back to the enforcers that I worked with, those individuals had substantial careers of repetitive neurotrauma that had careers with repetitive neurotrauma. On average, 200 fights. Not one of them was in a bad way. And, you know, they're 60, like the clock's ticking. You know, when is their symptom burden going to be elevated? But if you looked in their brains, would there be evidence of CTE? Probably in some of them. But that's what happens when you do highly selective case studies and then express a narrative, and then it's almost considered a done deal. People don't do the science. They don't even think it's necessary. KJ?
Softball question.
Oh, no.
So, I remember when the NFL came out with helmets that had accelerometers in them, so you could measure forces to the head.
Mhm.
I don't know if they're still using those or not, but
I don't think the NFL is
okay.
anymore.
Is it possible to use that data as objective data for the actual forces that people are undergoing during a game and use that to correlate other things that they might be complaining about, symptomology and other kinds of off-field measures? And two, what really happens in that little blue tangent?
Impact testing, SCAT scores.
Is that but seriously, for the second part, it's standardized.
And within sport, it's standardized.
Okay.
Yep. First question. Anytime you have a major sports organization with data, good luck.
Yeah, especially the NFL.
Well, I mean, I think all of them, because you'd have to think about, we own it, first of all. Why would we release it to you? What's the benefit to us? What's the likelihood that you're going to learn something about what's happening here that's going to be spun in a way that's detrimental to the business model? So I think anything like that was for their internal use only. And I think it would be, I would bet that you'd never, ever be able to access those data.
At any level, collegiate or?
NFL, no, but collegiate's big money too.
Yeah.
So I don't like your chances, but you can ask. Yeah.
Not looking for
I know. You probably have enough to do.
I do.
Yeah. Great questions, everyone, by the way.
Did you say that in the 200 hockey enforcers study that none of them are showing symptomology?
Well, it's a sample of 10, but it's a sample of 10 people that, if you follow the sport, would be household names. Like, these are very prominent people who would have been exposed to, a lot of neurotrauma. And I met with them and had long interviews with them. And one guy said, I couldn't remember, he's 60. I couldn't remember the name of a tree the other day. And I'm like, yeah, you're 60. Like some of it is just kind of, it is what it is. But that was literally the extent of cognitive disruption in that sample. They probably do. but they're all working. I mean, they all work at high level professions. They're not sitting under, like, the narrative is these people are a disaster. It's just a matter of time before we find them under a bridge somewhere muttering to themselves. That's the narrative that's being spun out there in the media for the hockey enforcers in particular. Yeah.
What your are on critical, especially in athletes such as like hockey players or racers where they're already a big like balance control, so they may have like it not showing signs immediately.
Well, I'm less familiar with like downhill skiing, for example, but what I see generally speaking, whether it's the Olympics or pro sport, is that there's a pretty conservative approach nowadays. Like back in, 20 years ago, we'd want them back, the next day. Now, if someone has a concussion, at least in ice hockey, it's almost expected that they're out for a minimum of 2 weeks, probably 3, and no one says anything anymore. It's like, yeah, it's going to take time. In fact, that's the mantra now, is these things take time. There is only one thing that will essentially allow you to recover, which is time. And people understand that, despite some people trying to get people on bikes early, and not sure why they do that. But I'm not as familiar with downhill skiing, but I would think the IOC has some pretty conservative rules about people returning to sport if they've had a documented concussion.
There are balance-related testing protocols too, right, which I don't think they use in most sports.
I think SCAT is probably what they rely on in the blue tent, and in the SCAT sport concussion assessment tool, yeah, there's an MBES in there. Yeah. Because everybody's got to be represented. Yes.
Well, I'm gonna speak for you again. I mean, everybody on Zoom, thanks so much for being here and for, I know we missed some of the questions, but we did our best. And thanks for being so patient with the technical difficulties.
That's my I initiated it, so
Yeah, it was a test. Thank you.
I failed.
But we can wrap up the Zoom, and thanks again for being here.
Yeah, my pleasure. Thank you.